It's my privilege to introduce Charles Ingaglia. For over 15 years, Chuck, has been a tireless advocate for mental and behavioral health care. He currently is Vice President for Public Policy at the National Council for Community Behavioral Health Care, which is a nonprofit organization that provides a unifying voice for 2,000 now. Is that right? I had 1,900, but I guess we're up to for 2,000 mental health organizations across the country. Mr. Ingaglia directs the federal affairs function of the National Council, providing counsel, advice, and technical assistance to mental health, on key issues in mental health care, healthcare parity, healthcare reform, access to community health care. Charles Ingaglia has a Master in Social Work and a Bachelor of Arts in Social Work, both from Catholic University of America. He's an adjunct faculty member at George Washington University Graduate School of Political Management. He teaches a course in mental health policy in Congress, which I'd love to take, and another course in the politics of nonprofits. And in his spare time, Chuck provides individual and group counseling at transitional shelter centers for the homeless in Washington, D.C., and he flies all over the country spreading the good word. So please welcome our guest, Charles Ingaglia. Yep.
Okay, so unlike Dr. Brown, I didn't get good public speaking advice from my mother. I got it, my best advice recently was last week at our annual meeting in Chicago, where Daniel Pink, who's a business writer, and he described himself as having a noble cause of being a business writer, and before he had that noble cause, he wrote political speeches. And he said the 3 keys to political speaking are levity, brevity, and repetition. So I will try to employ at least 2 of those, and you can tell you tell me later which 2 I employ tonight. So I have the privilege of working for this not-for-profit organization based in Washington, D.C. And even though we're based there, we represent organizations that provide mental health and addiction services around the country. So I love when I get to come out and talk to real people and hear real things about problems that are happening in your communities. And we had a very interesting dinner before tonight. Now, public policy and philosophy might be similar to some people because they're both kind of confusing. And my task tonight is to try to give a 30,000-foot view of what's happening kind of in mental health policy, and then to talk a little bit about that in the context of the Affordable Care Act. So that's what I'm going to try to do tonight. And, you know, I thought the previous discussion was really interesting about how complex this all is, right, to conceptualize what we're talking about. And yet, for those of us who have family members who have mental illness, or, you know, we walk down the street and we see people who are obviously living with these illnesses, that it's hard to deny that they're real and that treatment is necessary and is frequently effective. You know, I lived in a household where my mother had a very serious anxiety disorder, wouldn't even go out of the house to get her hair cut. And I remember for years I asked my dad, what's going on with Mom? And he'd say, it's the change of life. And I'd say, I don't think that lasts 20 years. You know, or I had the experience of my wife after the birth of our son, which was a very joyous occasion. She went into a really significant depression, and within 2 weeks of taking antidepressant medication really became a new person. So we have plenty of examples of personal examples of the kind of the reality of these illnesses and the effectiveness of treatment. All right, so I want to talk a little bit about, you know, kind of what's the context of mental health care, because I think the kind of overall rationale for tonight's or this next few days event, which is really how do we build public will about mental health. So I want to say just a couple words about from talking to our members around the country, what are we experiencing? And this was certainly echoed at the dinner conversation that we had before here, which is we've got this strange phenomena happening, and it's probably both of these things are due to kind of the national economy, national and state economy, which people are losing their jobs. That's triggering anxiety and depression and other kinds of reactions as they lose jobs. People don't have insurance. So what we're seeing around the country is that more and more people are showing up seeking publicly financed behavioral health care, and yet as this is happening, this is exactly the same time that there are fewer and fewer resources. So we've got this strange situation happening. At the same time also, I think our field, and I'm going to speak as an insider, the mental health field and substance use field, we've historically been separate from the rest of healthcare, and Dr. Brown did a good job of kind of talking about some of that. But what we're seeing right now is both this push to be more part of healthcare, and that is bringing with it unprecedented changes in the way that our systems are financed, organized, and the expectations placed upon behavioral healthcare organizations. So we're seeing different kinds of payment. We're also these new expectations around integrated care, and I know that's really going to be the topic of tomorrow's conversation. But think back to that slide from the earlier presentation about the overlapping comorbidities, that it's very clear that these chronic illnesses run in packs, and that frequently mental illness and substance use is part of that. I think also just as interesting thing that's happening in the broader healthcare field also is the role that technology is having in transforming care, both in terms of interventions as well as publicly available, transparent information. And I think those are going to be interesting things into the future about our healthcare system generally. I actually think that technology is going to be the most transformative thing in healthcare, even outside any of the policy developments that occur. All right. So think back with me before the last election. Can people think back that far? Before the last presidential election. And there was common agreement, right, that something needed to be done in this country around health care. And if you remember, all candidates who were running at one point, Barack Obama, Hillary Clinton, and John McCain, all had proposals around fixing the health care system. And the rationale, I think there's common agreement on what are some of the problems in our current healthcare system, right? That we have a growing number of people who are uninsured. Last count, somewhere between 49 and 51 million people are uninsured in this country, and if the Affordable Care Act does not go forward, that number will only continue to grow. We've also got this interesting conundrum. We have overuse of expensive, high-cost tests and procedures, and underuse of prevention, early intervention, primary care, and behavioral health services. So we've got this situation in our country where healthcare continues to consume an ever-growing proportion of gross domestic product. More and more of our spending is going to healthcare. And you've probably seen the charts, right? We spend more on healthcare than any other nation by far. France is catching up, but we still have them beat by at least 30 or 40%. But we're also number one in this other category, which is number of preventable deaths per 100,000 people. So we spend more than anybody else, but we also have not as good outcomes as one would expect that if we were spending that much. And part of it is this imbalance between where spending is happening. And then we also have a lot of medical errors due to poor coordination among providers. So it's estimated there's a lot of waste in our current system. I think there's a lot of agreement about that. No matter what party you're from, what your political affiliation is. But I think what becomes more complicated is then what is the solution? And I'm not here tonight to say that we have a perfect solution, but what I was asked to do was to talk a little bit about the Affordable Care Act and what does it mean for behavioral health services. So that's what we're going to turn our attention to now. And the previous discussion made reference to this idea of parity, which might seem kind of self-evident, which is this idea that mental illness and addiction disorders should be treated like every other kind of health condition in terms of insurance coverage and payment. So that if you go to your physician because you have a broken bone, you broke your arm, skiing or on the snowmobile, that you usually have a 20% copay, and there's not a limit necessarily on how many times you can go back to see your physician to get your arm fixed, or you might need physical therapy or other kinds of interventions to help you get full mobility back in that arm. But historically, there have been differences related to mental health and substance use treatment, that the copays have been higher, that there have been limitations on the number of visits. And now we have over 30 states that have some kind of state parity law, as well as now federal standards saying that, no, this is no longer should be the case, that mental health and addiction disorders should be treated like every other illness. So I'm going to talk a little bit about the overall structure of the Affordable Care Act, and then talk more specifically about how does mental health and substance use treatment fit into that. But I think this notion of parity is really paramount, because in the thousands of pages of statute, of legislative language that comprise the Affordable Care Act, there was not a lot of special attention to mental health and substance use. And sometimes advocates say, well, why is that? And it's because mental health and substance use were seen just like every other kind of condition. We were included, mental health and substance use was included along with everything else. So there wasn't a lot of special attention because it was just assumed. Of course, that's part of it. And I'm going to talk about that a little bit more. And then, did you ever hear that old Chinese curse? Be careful what you wish for. Well, the mental health and substance use community for years has been saying, all the way back, that we want to be treated like everybody else. The whole argument about parity, right, is our diseases are just like every other kind of disease. We should be treated the same way. President Clinton had a White House commission on mental health that, and they talked about the importance that Americans realize that mental health is fundamental to health. President Bush had a mental health commission that came out with a very similar recommendation in 2004. And the Affordable Care Act kind of picked up that theme and said, of course you should be treated the same way. And then this goes back to, I think, some of the disequilibrium that the mental health and substance use community is feeling, because we've always been kind of separate from the rest of healthcare, and we've had separate funding, separate regulations, separate ways of operating, and now we're being asked to actually relate to the rest of healthcare. And I think that's also going to be a theme for tomorrow. So if we think back then to what are the problems in terms of lack of coverage, of the wrong kinds of incentives, that we over-incentivize expensive treatments, we disincentivize preventative treatments, that we have poor coordination. Well, the Affordable Care Act makes attempts then to answer those problems. And it does so in four fundamental ways. Building on our existing system, no country that has sought to provide universal coverage has done so by taking whatever healthcare system existed, throwing it away, and starting over. Every other country, what they've done is they said, what do we have? How do we make it better? And spread what we have. And that's exactly what the Affordable Care Act tried to do as well. It tries to build on the private insurance system, but it says, private insurance needs to be a stable and reliable partner. So we need to do some insurance reforms, and I'll talk a little bit about those. It then seeks to then extend coverage both through private insurance as well as public programs. And then most importantly, it tries to get at delivery system redesign and payment reforms. And granted, it doesn't do those as well as I think people would like. And I would think about healthcare reform or the Affordable Care Act as phase one in an evolution towards reforming our system. But I don't think you can really, this is a slide I skipped over, that there are some pillars here, right? That you need access to insurance, you need a broad array of providers, you need good benefits, but you also need to think about quality and cost control. And I think the delivery system redesign and payment reforms are attempts to get at that. So what are some of the insurance reforms that are in the Affordable Care Act? And again, it goes back to this idea that private insurance needs to be a reliable and stable partner. What ends up happening now frequently is that there are it's difficult if you don't have employment to purchase insurance, that there are limits on what insurance covers, and people that end up going on to public programs. So there are a number of insurance reforms. I'll just name a few. Things like requires insurers to issue policies to people who seek them. The prohibition on annual and lifetime limits on kind of dollar benefit of insurance products. That you can't exclude people based on pre-existing conditions, and then also that you create essential health benefits, that there's got to be a core set of services that every health plan offers. This relates both to plans offered through these newly created health insurance exchanges, as well as to certain other plans. And importantly, mental health and substance use disorder coverage is mandatory and must be offered in compliance with federal parity system. So I teach graduate school, and I always say things to my students like, you guys remember Clinton healthcare, right? And they get these blank stares back because they're all so young. But back in in Clinton, the Clinton administration, when they were talking about healthcare, one of the things they did, right, that this Congress tried to avoid is, if you remember back into the 90s, they wanted to get all of the details right at the legislative stage. Remember, they spent over a year debating what the benefit package would be in that insurance plan. And I could just say that mental health and substance use wasn't even given that it was going to be in, and it certainly wasn't going to be in at this idea that it's going to be treated just like everything else. So this was a huge milestone. As part of the insurance reforms also, it requires plans to meet certain thresholds of actually using premiums to provide healthcare services. That's sometimes called medical loss ratio, that actually, depending on the type of plan, either 80 or 85% of the money you collect in premium actually has to be used in providing care. And we're starting to see already insurance companies giving refunds to insured because to meet this standard. And then also sets up kind of procedures for monitoring rate increases of health plans. So how much can you raise the premium per year, and what is the standard for that? All right, so because we have 49 million people in this country who are uninsured, and all of us in one way or another pay for their coverage when they show up at emergency rooms, the other kind of pillar of the Affordable Care Act is to try to expand coverage. And it does this by requiring individuals to have coverage. I have a slide later talking about the Supreme Court case, so we'll come back to that. But it tries to do this. It not only says that you have to do this, but it also tries to make sure that coverage is affordable, and also to offer credits and subsidies to people between 133% of poverty and 400% of poverty to try to make that coverage affordable. All right, and then we create these state health insurance exchanges, which I think the easiest way to think about that is think about your state health insurance exchange as comparable to Expedia, where it aggregates all of the different options that are available. You type in who you are, what size your family is, what your income is, and it spits back to you what the options are, the same way that Orbitz or Expedia does that when you're looking for an airfare. And the whole idea there, right, is that as individuals or small employers, it's hard to get the best price on insurance because you have a very small number of people, either one or two or three or four, that you're trying to get covered. And the advantage, right, that large businesses have is that they have a larger pool. pool. So what a state insurance exchange basically does is create a larger pool to spread risk, to then make things like mandatory issue and those other insurance reforms, kind of palatable. So the other way that the Affordable Care Act approaches coverage expansion is to build on existing programs. And so remember I said that the subsidies for purchasing insurance in the exchange are for individuals or families between 133% of poverty and 400% of poverty. And for people at 133% of poverty or less, they're going to be eligible to have coverage through Medicaid. Now, this was not a done deal. During the Affordable Care Act, there were a bunch of different scenarios that were put forward, and we have this thing in Washington called the Congressional Budget Office. And the Congressional Budget Office, some member of Congress has a bright idea, they draft legislation, and it gets introduced in Congress, and if it is lucky enough to be the 1 or 2% of bills that actually move, that actually seek committee time, and then that piece of legislation goes to this thing called the Congressional Budget Office, and they try to estimate how much that piece of legislation costs the federal government. That's their job, is to figure out what's the price tag associated with this great idea. What's it going to cost the federal government? And there were a bunch of different scenarios that were drafted during the Affordable Care Act. One of them would just be that we would purchase insurance for everybody and subsidize that purchase through the exchange. And it actually turned out that, according to CBO projections, it was cheaper for people to have, at certain poverty levels, to have Medicaid coverage than to actually subsidize the purchase of their insurance in the exchange. And so that was one of the reasons that actually happened. So basically, for those of you who are familiar with Medicaid, since its creation in 1965, there's basically been a two-pronged test to determine if you're eligible for Medicaid. One is, what is your income? And the federal government creates, some basic standards, and then states have a lot of flexibility in, kind of going above those standards and saying how much money people can earn in order to qualify for Medicaid. So that's been one test, is what's your income? And the second is, do you fit in an eligibility category? Are you a pregnant woman? Are you a person with disability, et cetera? And basically what the Medicaid expansion and the Affordable Care Act says, we're going to take number 2 off the table. It doesn't matter who you are. You don't have to be in one of these eligibility categories as long as you meet the income standard. And then the other thing it does is it creates national standards for determining income. So because right now every state has its own standard about how do you actually determine if somebody's at 133% of poverty. So this will have a huge implication for childless adults. And we know that that's a population that has a high rate of both mental illness and substance use disorder. So we also think that Medicaid expansion is going to be very important. One of the other insurance reforms that I didn't mention was that young adults up to the age of 26 can stay on their parents' insurance. And then for the Medicaid expansion, it is a comparable thing for children that are in foster care, that states would have the option to keep kids in foster care on Medicaid until the age of 26 as well. All right, so this is a 30,000-foot view about the Affordable Care Act. I'm happy to answer questions. But again, if I think about this in the context of what does this mean for mental health and substance use disorders, that we're a required benefit in private insurance, we're a required benefit in this Medicaid expansion, and that federal parity also applies. So we have this kind of situation now where all insurance coverage into the future will have a baseline mental health and substance use benefit. Now the question is, how generous is that benefit? And that's still something that is being discussed, and we'll talk more about that. But I think it's a kind of a radical position given where we've been over time, where we have tended to be excluded from most other programs, and the Affordable Care Act certainly takes an approach of inclusion. All right, I'm going to talk a little bit about delivery and payment reforms. And the Affordable Care Act doesn't say that, we've got a magic bullet here. What it tries to do is say, well, there seem to be some good ideas out there. Let's test them. Let's see if they work, and if they work, let's expand them. And the good ideas try to get at this, one of the problems that we talked about earlier, that I think there's common agreement that we've got misaligned incentives, that we spend a lot more of our money on high-cost, intensive interventions, less on prevention, primary care, and behavioral health. So a lot of the delivery system and payment reform ideas that are in the Affordable Care Act are things about how do we coordinate care and try to better align incentives so that we intervene earlier, try to prevent chronic illness, and therefore to reduce overall spending. So it's things like we've heard about accountable care organizations that will be rolling out in Medicare, and it's also things like medical homes, and these all kind of have some common features that they try to intervene early. Care management is a feature of that, and that's this basic idea, right, that how do we help people coordinate care better? I don't know if any of you have had this experience. My dad had Parkinson's disease and had chronic heart failure, and he had a bunch of other problems, and I'd come home, I'd fly to Detroit from Washington, and I'd take him to his neurologist, and his neurologist would say, well, I think we got to change this med over here, and let's put him on something new. And then I'd come home a couple weeks later and I'd take him to his cardiologist, and he'd say, oh, I don't like this med, I got to change that. And, and then I'd take him to another doctor, and I'm 500 miles away trying to coordinate my dad's care. And most of us, if we have more than one specialist that we see, that's a similar kind of problem, right? That there's nobody who's actually trying to coordinate that care to make sure that there's conversations happening between all of those different specialists and think about what's best for that individual. And that's this idea of care management. How do we then help people navigate that so that they have somebody who actually knows what they're doing, not someone like me who's trying to do that. And then there's other ideas here around partnerships with primary care, data collection. This goes back to HIT. That the foundation of any kind of transformed system is going to be the ability to share information between providers around common patients, so that if you have a motorcycle accident on Friday night and you show up in the emergency room and you can't talk, that emergency room has a way to have some basic information about you, what medications you're on, et cetera, in order then to avoid adverse drug reactions. And then this idea of clinical accountability. So one of the ideas here is that if you look at accountable care organizations or health homes, the idea is how do we invest accountability closer to the ground at the community level and amongst providers? Because right now, you've got a health plan who is thinking about overall spending, but not necessarily individual clinicians who are thinking about either spending or, so the idea here is how do we move that down a rung and actually have accountability both for quality as well as cost at the level of the provider. So one of the ideas then that is expanded into Medicaid, and that's this idea of creating a medical home. And a medical home is not a physical location. It's not like it's not an average census or length of stay. A medical home is a practice that takes responsibility for individuals over time, provides that care coordination, invests in prevention, et cetera. And there's a new option in Medicaid to create this kind of system. And it's targeting individuals with chronic illness. I know Wisconsin is in discussions with the federal government about creating a medical home for people with HIV and AIDS. And it also has, beginning the process of thinking about what would a medical home look like for people with behavioral health conditions. So this is not something, far, far away. This is something your state is actively thinking about. And again, that this this option in Medicaid specifically targets people with serious mental illness and allows behavioral health providers to be medical home entities or health home entities. So this was, again, up to this point, every other federal initiative around disease management or care coordination has explicitly excluded people with mental health and substance use conditions. This is the first time where we're specifically included. All right, so I just want to talk a little bit, kind of gave the 30,000-foot view of the Affordable Care Act, but what's the kind of other things that are swirling around in the environment that are going to affect all of this? Certainly, the mood in Washington is not about expanding any kind of program. It's about cutting. And last year, as a kind of condition for increasing our nation's debt ceiling or the ability of money we could borrow to finance the federal government, there were deals made about reducing federal spending. And if you could remember, then there was this committee that was established that was tasked with finding somewhere between $1.2 and $1.5 trillion in extra money laying around, and to come up with a consensus opinion about what should be cut. As you all remember, that committee did not reach consensus. So now the poison pill that was included in the creation of that committee is if you cannot agree on these cuts, then there'll be an automatic process of reductions that will kick in 2013 to all federal programs, both defense and non-defense. So just to give you a sense of that, if in order to reach that target, the Department of Health and Human Services, which houses everything from SAMHSA, which is the Substance Abuse and Mental Health Services Administration, the National Institutes of Health, the Health Resources and Services Administration, which administers federally qualified health centers as well as AIDS programs, the Centers for Disease Control, other programs within HHS, that in order to meet this target, this would be a 7.8% cut across all HHS agencies if it were applied equally. But the National Institute of Health is not going to take a 7.8% cut anytime soon. No one is going to take that kind of money out of our nation's research. So that just makes then that the cut to other agencies within HHS would likely be larger. The other part of this is that there are 10-year spending caps on federal non-defense discretionary spending. So for the next 10 years, there cannot be increases in the amount of discretionary spending. But we also are hearing, right, that people don't like this idea of cuts coming from defense spending, that the idea that these cuts would be spread equally between defense and non-defense spending is unpalatable to some. What I fear is that and all of this will be taken out of non-defense mostly health programs. So we have no idea, kind of how this will play out. This will likely be a lame duck issue. So after the presidential election, we'll see some activity there. The other thing in the wind, right, that we've heard a little bit about is the Supreme Court challenge to the Affordable Care Act, and there are basically three major questions before the court. One, is the individual mandate constitutional? Is this idea that the federal government tells people that they have to purchase insurance, is that constitutional? Now, every week when we get our paychecks, or every 2 weeks when we get our paychecks, there's an automatic deduction both for Social Security and for Medicare. So some people have opined, how is that different than this mandate to purchase insurance? I'm not saying I'm opining, others have opined that, but that's a question, is the individual mandate constitutional? The second question is, if the court finds that the individual mandate is unconstitutional, can the rest of the law stand, or must the entire law be stricken? Now, only one lower court that has found that the individual mandate is unconstitutional has said that the entire law would have to be stricken. So it's hard to know, what will happen with that. And third, the question of, is the Medicaid expansion an unconstitutional infringement on states' rights. So those are the three questions before the Supreme Court. I'm sure all of you were watching, watching all the news coverage a few weeks ago when the unprecedented long hearings or kind of statements were given to the Supreme Court. We expect, everyone thinks that the court will rule sometime in June, but the question will be, if not the Affordable Care Act, then what? Because we're still going to have the problem of an ever-growing proportion of gross domestic product going to health care. We heard just this week about the Medicare trustees report about, insolvency date, et cetera. So there's going to be there will have to be some kind of attention to health care reform of some way, shape, or form, even if the Supreme Court strikes down the Affordable Care Act. And this is usually my message to mental health and addiction providers who want to say, can't we just everything just go back and be the same? And I say, I think the genie's out of the bottle, right? I don't think we're ever going to go back to things being the same. I mentioned earlier about, unprecedented demands for services while investment is decreasing. The National Association of State Mental Health Program Directors has documented over $4 billion in cuts to the state mental health system over the last 3 years. I don't think we're ever going to get that $4 billion back. I mean, even as state revenues begin to look better, we're never going to go back to the way things were. The other, kind of variable that is emerging, right, is unlike health reform in the 1990s, this Congress chose not to try to figure out every single detail of how this would work. I think it's been said that the most frequently cited words in the Affordable Care Act is the phrase, "the Secretary shall," which means we're going to make, kind of broad kind of decision, and then Secretary, you figure out the details. So we had this idea that there'd be essential health benefits, and I think people thought or hoped that basically the federal government would say, okay, in these 10 categories, these are the exact benefits that you have to offer, and this idea of essential health benefits that would be covered by health plans in the exchanges. But HHS didn't do that. What they basically said is, we're going to give you a number of options for choosing a benchmark for those benefits. Good luck. And so, the question then becomes at the state level, what decisions are made about what the benefit package will be. We know that parity does apply. That was part of the guidance from HHS, that parity does apply, but then the question becomes, how does that actually get operationalized? All right, so I'm just going to say that there are lots of ways for you to follow kind of what's happening on a policy front, lots of ways that you can be involved as citizens. I think the other good thing is that there's a lot of transparency happening right now, and if you subscribe to any of the National Council's newsletters, we try to keep you appraised of what's happening. We also offer a bunch of webinars that are free and open to the public about a variety of topics. You can check us out on Facebook and Twitter, and we have a blog. So there are lots of ways that if you're interested at all in these topics that you can follow them. And I would get in trouble if I didn't encourage you to actually come to Washington in June for our Hill Day and to learn more and to also to advocate. So I think we're going to have a question and answer period, and I look forward to that. Thank you.
Myself and Evan have microphones, so raise your hand and someone will come and give them to you.
I don't know if this is a policy issue, but just a question. I think maybe Dr. Brown might address this. I'm not sure who. It seemed to be a comment around as we progress into the future here that with integrated care, it seems like I'm in a mental health facility. I either should be working in a primary care office or they should come to mine. Is that kind of some of the thinking?
Certainly some of the thinking is that preventive services, which can be particularly important in mental health services, can be conducted effectively through primary care providers, who then may have somebody on staff, on location, on site, so they visit a need, they get another appointment, or to make referrals to a mental health professional if the problem is something that cannot be dealt with in a primary care setting.
Mark, could you press your microphone, please?
Okay.
Thank you.
I should not do this. There we go. Can you hear me now?
Yes.
So sir, your question was, if I understand, why not primary health settings as opposed to hospitals?
Or maybe more, is there a thought that the best practice would be meeting the client jointly in a setting that would either be at my site, where the doc would come, or at their site, where the therapist would go, or something on that order, because we don't do that. There's large hospital systems in this community, and I don't believe in the building there really is any behavioral therapist. And I was just thinking about that when you were talking about, is that what's starting to be talked about?
I think you're correct that in many large hospital settings, there is much less in the way of behavioral and mental psychiatric care than one might wish. I also see that it's sometimes maybe best to go on site and see what's really going on. Have somebody come home. That would be yet a different service, which may be best sourced through a single site, a single case manager, somebody who is responsible for taking care of the whole person. And that certainly includes your home and everything else that's going on there.
I just say, the part of why we think integration is becoming so important and why, it's no going back is if you look at people who have chronic health conditions, that they tend to have a co-occurring mental health and substance use disorder. And if those disorders are not treated, the cost of treating their medical condition is more expensive. And the same is also true for people who have mental illness, that if their medical conditions aren't treated. So that's why we think that why behavioral health is going to be so important into the future, being able to screen for, identify, and treat mental health and substance use conditions. Now, what a consultant that we work with a lot when he talks to behavioral health audiences says, we think you have a lot of possibility into the future. There's going to be a lot of demand on your services. You might just not be working for the same organization 10 years from now that you work for now. There's going to be, so I think what you're talking about co-location, certainly we're seeing both, kind of policymakers and others thinking that safety net clinics in the future will co-locate primary care, mental health, and substance use in one place.
I think that some family physicians in this community, in this county, practice integrated health care. If it was ideal and perfect integrated health care, more coordinated, with substance abuse treatment and mental health, how would you tell me about that model? What else would be done?
So, I think there's some basic things around what kind of collaborative relationship, so what kind of screening is happening at primary care. So how are they identifying underlying mental health or substance use conditions? What kind of capacity then do they have to treat those on site? What kind of collaborative relationship do they have with specialty providers to ask them questions? I was at a briefing yesterday around children's mental health hotline in Massachusetts, where primary care doctors who are seeing something that they don't really understand what's happening, that there are psychiatrists on call that they can call and get opinions from. So I think those would be some of the core elements, and I know we're going to get into more of this tomorrow.
Primary care physicians are very busy people. They're booked. Asking them to also be a therapist. Asking them also, primary care physicians are busy. Asking them also to be a therapist is an additional burden. And most integrated care models do not put primary care physicians in that position. What they do is they provide screening in some cases, additional staff for brief intervention. Some of those may be trained specifically for brief interventions and counseling for particular disorders such as depression or substance abuse. We'll hear about some of those programs a bit more tomorrow for those of you who are going to stay. The primary care physician is not necessarily supposed to be the one who keeps all the balls in the air and provides comprehensive care. Primary care is where almost all of us go initially for our health care. So it is a point of entry and consequently a point of opportunity for providing comprehensive and continuous care.
I was just wondering if there's a segmenting of the consumer population into a acute category, short-term intervention, a chronic, less severe category, and the Dane County model or assertive community treatment model recognizes there's a more intensive need, smaller caseload model.
Yeah, the National Council, the organization that I work for, about 10 years ago, kind of took a look at this issue, and we came up with this 4-quadrant model, and it's exactly what we look at: level of severity, both in terms of mental health and substance use condition and medical condition, and then trying to figure out what are the types of services that people need in each of those quadrants, and where should those be delivered. So we think for people with mild or moderate depression or anxiety, that with proper supports like care management and psychiatric consultation, those folks can usually be treated in primary care. But there are going to be more intensive interventions that people with more severe disorders need, and that's why we have a specialty system, right? So it's the same, same way that primary care doctors are not oncologists, that they're not endocrinologists, that there are specialists that they consult for those illnesses. So we certainly think there is a very important role for specialty behavioral health care in the future. There's no way that primary care practices are going to provide assertive community treatment or other kinds of intensive services.
Okay, I think we have time for one more question.
I've heard anxiety and reservations expressed amongst mental health providers and medical providers that if this reform goes through, that the government will control all the fee schedules of reimbursement, and we will all be working for Medicaid or Medicare fee levels. What control will the government actually exercise over reimbursement rates?
So only about half of the people who would gain coverage as a result of the Affordable Care Act would be doing so through, less than half through Medicaid. The majority of those folks would gain coverage through private health insurance. So the government would not be, controlling, the fees paid for in private health insurance. Although the reality today, right, is that Medicare is usually the benchmark for all other fees. So to some extent already, the Medicare creates, kind of the floor for reimbursement.
One last point on this. The Affordable Care Act does include support for integrated care programs and upscaling them and providing research on their effectiveness. But it is one component of the Affordable Care Act which has an independent momentum that even if, Chuck can tell me his view on this, even if it goes down in the Supreme Court or the presidential election or the deficit reduction, large insurance companies are interested in this too. Kaiser, for example. And there are many private sector providers who recognize both the importance and the inherent efficiency of treating chronic conditions, including mental health conditions, in a comprehensive and coordinated way. So I think this is a 21st century trend that will continue independently of the legal and political framework which is developing in DC and Madison.
Okay, in the interest of keeping on schedule, I think we'll conclude there. Can we have a round of applause for our guests, please?